Historically, notes have just been a billing tool, right? That's what they've devolved into is I need to do this so I can bill and get paid for the services I'm providing. But in reality, they're a communication tool. Physicians aren't burned out because they're seeing patients. They're burned out about all the other crap that they have to deal with.
Exactly, because they're not seeing patients and they're using time to not see patients.
Value-based care to me is really thinking about how do we align payment to patient outcomes. If you think about it now in a fee-for-service world, payment is really, you do something, you get paid for it. And that's just not the best way to practice medicine, especially oncology, in my opinion. My wife and I are sitting at the table and I go, can you believe this, honey? This new drug for treating cancer is $40,000 a month. So we can talk all day about what's wrong with the world.
Let's talk about what we can do to make it right.
Talk about what we can actually do to make it better. I love that. So
what if rethinking the payment model in oncology is actually the fastest way to improve patient outcomes? That's the question I explore today with my good friend, Dr. Lalan Wilfong, a practicing oncologist and the Senior Vice President of Value-Based Care at Thyme Care. Thyme Care works with payers and oncology practices to manage population risk, support patients between visits, and prevent avoidable acute care. In other words, they're building the operational muscle that fee-for-service was never designed to handle. Lalan has spent years leading value-based care initiatives at Texas Oncology and the US Oncology Network. Today, we break down why fee-for-service falls short in cancer care and why aligning payment with outcomes, not volume, is essential if we want a more sustainable, patient-centered healthcare system. We talk about how value-based oncology actually works, how risk models, proactive outreach, and continuous support can dramatically reduce hospitalizations, and how caring for patients between visits often moves the needle more than anything else that happens in the clinic. We then explore what it takes to make value-based oncology durable, operationally, financially, and culturally across clinicians, payers, and technology partners. Finally, we turn to AI adoption, where it helps today, where it creates friction, and what it would take for AI to become a true partner in value-based care. This is where Lalan offers something really rare, the honest perspective of a self-described late adopter who after 2 years finally gave DeepScribe a shot. His reasons reveal a lot about the real barriers to AI adoption and what technology partners must understand if they want their tools to stick. If you're building or operating value-based programs or building technology and driving AI adoption, this conversation gives you practical insights that you can use tomorrow. Let's dive in. So Lalan, why don't we start by just telling the audience a little bit about you and kind of your path to where you are today?
Medical oncologist, started practicing a long time ago, back in 2003. So yes, you can do the math. I'm in my 50s. I know I don't look it. But yeah, I started practicing at Texas Oncology in 2003. Loved practicing medicine. Thought I was just going to practice medicine my whole career in my clinic. But then in 2015, I got pinged by who was and my mentor, Dr. Russ Hoverman, who led all the quality initiatives at Texas Oncology to help with some of the quality initiatives. Funny story, he literally called and said, hey, I'd like to come speak to you. And when Russ came to speak to you, it was never good. And so for like 2 weeks, I'm freaking out thinking I was going to get fired. And he walked in. I was literally just wondering, asking my partners, did I do something wrong? What'd I do? And they're like, I have no idea why Russ is coming. He came inside my office and I was like, am I getting fired? And he just busted out laughing. He goes, no, I want you to help with quality initiatives. I was like, oh, that sounds like fun. So I started that in 2015. Literally about 3 months after I started doing that work, he said, there's this little bitty program called the Oncology Care Model I would like you to lead for Texas Oncology. And the Oncology Care Model was a CMS derived value-based care program for oncology. It was the largest at the time. And it was about half of all of Texas Oncology's patients were in this model, which I didn't know and I agreed. But very quickly that became more of my full-time job. And I had to cut back in clinic, start doing that more, realized I loved this work around value-based care and thinking about how do we align payment to patient outcomes and benefit. So fell in love with this work, started doing other initiatives for Texas Oncology. And then in 2021, I had the opportunity to go over to the US Oncology Network, where I led the value-based care program at the US Oncology Network. And the US Oncology Network is a network of about 30 practices across the United States, and many of them who are in value-based care programs. I got to lead the team that did our payer contracting and value-based care programs and all the analytics around that for a few years. And then in 2024, I got the opportunity to move to a startup and kind of experience the startup world. And that's where I am now as at Thyme Care, which is a startup in the value-based care space.
That's awesome. And I think like, you and I have talked a lot off camera about value-based care and why it's so important. But I'm curious if you can kind of just give like a 10,000-foot overview on what the EOM model is, what value-based care is, just for the audience that, may not be too familiar.
Value-based care, in my opinion, this is a Lalan Wilfong definition. So you may see something different on Wikipedia if you look it up. But value-based care to me is really thinking about how do we align payment to patient outcomes. If you think about it now in a fee-for-service world, payment is really, it is basically you do something, you get paid for it, as long as it's covered by insurance. And that's just not the best way to practice medicine, especially oncology, in my opinion. And studies have shown this. It leads to more testing, more treatment, things like that. And it does not reward physicians for having real conversations with patients and truly understanding what patients want and desire. It rewards volume and doing stuff versus the medicine that we do. And so, I've realized that for a long time. And from a patient perspective, fee-for-service world, lots of copays, cancer costs are expensive. I tell every patient when they walk in the door that you will meet your deductibles this year. So just be prepared. We have to figure that out with you, but you will meet your deductibles because cancer is super expensive. So value-based care, to me, realigns that. And really the goal of value-based care, in my opinion, is to align that payment with patient outcomes and benefit that is right for that patient sitting in front of you. So it changes the paradigm instead of a doing to an actually caring for patients. And so that's in my world what value-based care is. As far as boots on the ground, what that means, there's a lot of different flavors of it. Most of the time in value-based care arrangements, your incentive structure is changed to where you are responsible more for patient outcomes than you are for treatment. Many of the simple ones, look at an oncology space, acute care reduction. So keeping people out of the ED in the hospital, which as we know with cancer care and treatment, side effects and ongoing effects of the cancer tend to cause people to end up in the emergency room in the hospital for problems. So how do we proactively prevent that? And then how do we align better care at the end of life to where we're not treating people at the end of life, but we're actually helping them transition to more comfortable end of life care when that time comes. So those are the two big things from a patient standpoint. And then looking at the total cost of care and how do we derive treatment decisions that improve the total cost of care versus giving the most expensive new drug that's out there that may or may not actually be beneficial for a patient.
I mean, it sounds so obvious, right? Like practice the medicine that, doctors want to practice, take better care of patients and, really incentivize better patient outcomes and also doing that while reducing the total cost of care. It just sounds so obvious. I mean, but as you and I both know, like this has been in the works for a very, very long time. It's like lightning in a bottle, right? It's very difficult to actually execute really well. What do you think has been, the biggest delays or the biggest challenges that we've had to overcome as a healthcare system, as as oncologists, or, just as, from a policy perspective? What do you think some of the biggest challenges are and why we haven't been able to fully transition so as quickly as, we think we should have?
Some of it just relates to the systems that we've created and developed over the, 4 decades that we've been doing cancer care. The system from just a logistics standpoint isn't set up to do value-based care the way that we want to do it. Physicians are, in a fee-for-service world, the way we are incentivized now is to see patients. You have 15-minute appointments. You want to keep your patients on time, yada, yada. Because patients get a little mad if you're running late. The system just isn't set up to do kind of what we need to get done. There's a lot of things that aren't reimbursed that are required for value-based care. A lot of the nursing interventions, a lot of the conversations aren't reimbursed well. And so changing that just from a logistic operational standpoint can be really hard for our practice. And then from a payment system, that's really where I think the biggest barriers are. It's very difficult for a payer to completely change the way they pay, right? We're set up in a fee-for-service system. You build charges, you pay the bills, we have our contracted rates, and yada, yada, yada. Changing that is really hard. And then, like I mentioned, one of the goals is reducing the total cost of care. But what does that mean? Yeah, actually. And one of the greatest things about cancer care right now is the pace of change. I mean, it is so challenging for an oncologist to keep up with the drugs that are coming out and just the molecular mutations that we're finding. Is like every day something new is coming out, which is fantastic. I mean, we've really changed the paradigm of how patients are being managed and treated and what their outcomes are. I mean, it is amazing to me from just 10 years ago to where we are now about the differences in patient outcomes and benefits with the advancements that are being made. The biggest challenge with that, though, is what does that mean from a value-based care total cost of care standpoint? Because the cost of cancer care have risen dramatically over the past 10 years. A lot of that's appropriate because we have these new drugs and these new therapies that are out there that do so much better for patients. But how do you define total cost of care in a world that's rapidly changing? What is the benchmark supposed to be? And that's challenging because you don't have anything to compare it to. And very different. There's a lot of value-based care that's done in the kidney space. Dialysis, and hopefully nephrologists, if you're watching this, don't yell at me. Dialysis is a whole heck of a lot in the past 10 years or so, right? And so doing a value-based care program around something like dialysis is easier because the treatment modality hasn't really changed a lot. And so you can truly focus your value on the things that matter because your base hasn't changed. It's not the case in oncology. Dramatic paradigm shifts in how we manage patients and what those cost structures are right now. And so it's hard to figure that out. And that's really hard for payers to do, to figure out, what should the benchmark be and how am I holding you accountable for lowering the total cost of care? So that's been the biggest limitation, I think, from that standpoint, is doing that. And then the other one is just a lot of the cost of care for cancer outside of the people who manage its control. Meaning, there's all this stuff about drug prices and where is this money going for drugs? I can tell you it's not coming in the physician's pocket. A lot of it's going to other places. And how do we, in a value-based care world, solve that when that's a much more macroscopic problem with drug prices being so high? And so some of the ways that you can manage in a value-based care world from a physician, from a payer, is completely outside of that control. And it's just challenging to figure out how to do that.
Yeah. I mean, there's so many different things that need to change at every single step of the value chain in order for this to actually work.
Yep.
And I thought the point that you brought up around how, it's easier to implement in an area or a specialty where there's not as much change as we're seeing in cancer. It's interesting, when we were in Boston and kind of thinking through like, what are some of the accelerants around getting the payers to actually, align to some of the new evidence that's being produced? It's like a multi-step process, right? Just because, Medicare approves it, there's a separate whole nother process to determine whether or not a payer is going to approve it. And, it's a very tricky problem to solve. And, I'm curious, like, what do you think is the biggest accelerant, right? Is it generating more clinical evidence? Is it policy to making sure that the payers need to, accelerate their processes? Like, what do you think that is that, is if there's one thing that you can change, what do you think that would be?
The thing I would change is just how we pay and price drugs. If you think about oncology, it is a drug business, right? We give people drugs to treat their cancer. And, it's really, I was sitting there at dinner the other night. It was after dinner, actually, take that back. It was after dinner. My wife and I were sitting at the table. She's a podcaster too. She was working on her podcast. I was working on some stuff. And I go, can you believe this, honey? This new drug for treating cancer is $40,000 a month in costs. And she was like, you're kidding me. And I'm like, no, that is the AWP for this oral drug was $40,000 a month. And I remember when I started in value-based world back in 2015, one of the new drugs came out at 5,000 a month, and I was floored. Like, what does this mean? Now we're at 40,000 a month. And I think that's the biggest challenge is these drugs are coming out. They're really effective. Most of them are really effective at managing patients, making people better, but they're super expensive and costly. And if you think of it from a payer standpoint, they set their rates years in advance, right? I mean, your employer, if you have self-insured, and if you're a self-funded employer, you have those contracts for like they will start working on 2027 contracting starting in January 2026. And in the government space, they've already projected their budgets for Medicare, Medicare Advantage in early 2026 for 2027. And as this pace of changes happened, how do you incorporate that into your cost structure? And then who pays those costs? Is it patients? Is it the employer? Is it the government? Do we get more taxes? And so I think that's the biggest challenge we have is just you asked me what the accelerator was, and it's really challenging. You have to figure out what is the payment structure that we have in the US right now? How do we incentivize the right folks to do the right things? I mean, we're not going to have these new drugs unless pharmaceutical companies are incentivized to develop them. They need to have some incentives. Physicians to be able to be incentivized to be a physician and to manage their clinics and have their clinic, be running for patients. So you had to have the right incentive structures in place. And that's I say that it said that again, but it's a macro problem that we have to do that true accelerant that we need to do.
Yeah, I mean, there's a lot of companies working on that too, right? Like around price transparency, around drug prices. You can even imagine changing the useful life of the drugs, extending it beyond the 20-year lifespan that these drug manufacturers need to amortize the cost of R&D over. A lot of these things can be done to actually reduce the cost of these medicines. Right. But let's kind of move to like the area where we operate, right? Like I think that's at the macro level, but even at the micro level, you shared that you just started working at Thyme Care, and I think you guys have a really interesting model that is playing a huge role in reducing the total cost of care, aligning the incentives. Can you talk a little bit more about that and like why you decided to target that specific part of the value chain?
Yeah. Thanks for changing the conversation because we can talk all day about what's wrong with the world. If we're not going to
let's talk about what we can do to make it right.
Talk about what we can actually do to make it better. I love that. So, I joined Thyme Care mainly because I believe that the way that we at Thyme Care are looking at this problem is the right path forward right now. It's probably not going to be the right path forward 100 years from now, hopefully, but for right now, this is the way that I think we need to be thinking through this. And when I talked about benchmarking, one of the biggest challenges that I had in my previous life at Texas Oncology and at US Oncology, as we've tried to think about benchmarking, you have to have enough of a patient volume to be able to do that. There's a lot of variability. If you think about like breast cancer, for example, breast cancer is now probably 10 to 15 different substates with all different outcomes and cost structures and therapeutic choices and things, probably more than that if you divide it the right way. And if you're thinking about doing some sort of value-based care program, you have to have the volume to mitigate the variability to do that. If you flip a coin 5 times, you're not going to get a 50-50 answer. If you get to flip it 100 times, you're more likely to get 50 heads, 50 tails, right? So you have to have the volume. And so what we do at Thyme Care is we're able, because we're agnostic to clinics, to partner with payers and populations. And so we can partner with broad populations around risk. So we can use that volume to be able to manage that variability in the patients that are coming in the door. And then we can partner with practices on managing that patient population and so kind of do both. And so we can partner with payers, take the risk on a population, and then we can really think through how do we manage that risk well. And the way we do that, one of the biggest things that I'm a huge advocate for, have been for a long time, is managing people outside the 4 walls of the clinic. And in a fee-for-service world, you do not get incentivized to do that. I only got paid to when a patient sat in front of me in clinic. There's some codes now and some other things that make that a little bit better. But for most of the time, unless you're sitting in front of me and I'm talking to you, I'm not going to get paid. And so there's no incentive to really manage patients outside of our four walls. But that's where patients run into problems. The nausea, vomiting, and the neutropenia, the low blood counts, risk of infections, all that stuff doesn't happen when you're sitting in front of me. All that happens after you're at home. And so how do we make that better for patients? And so by looking at and taking risk with payers, it changes the way you think about that, because we get paid if we lower the total cost of care in that population.
Because you guys are taking risk, right, on the population.
Yeah, so we're taking risk. And so if we lower that total cost of care, then we can share in the savings with the payer. That's how our model works. So it really changes the way you think about that stuff. So now all of a sudden, I really care about what's happening with patients outside of my four walls, because I really care that they don't go to the hospital or the ED for something I can prevent. And I firmly believe that, and we've shown that over and over again, that keeping patients out when you can saves the system significant money. And it's great for patients too, because no patient wants to be sick enough to go to the emergency room, right? It changes that. And so we can focus on how do we manage these patients outside our four walls? How do we use electronic patient report outcomes, proactive nursing outreach? How do we solve some of their health-related social needs issues so they can actually access care when they need it? Because studies have shown that if you can't access care, you have more acute care utilization. And so you can focus on that differently, because you know that driving that benefit will lead to financial benefit for the company. So it's kind of a win-win to me, the way that we use our model to really focus on patient outcomes. So the patients do better, we lower the total cost of care, and then we can share in that savings with the payer.
Yeah. And I love that model, because I think so much of the conversation today is revolving around what's happening in the clinic. We work at the point of care with doctors. A lot of people are trying to go into the revenue cycle space. Everyone's focused on how do we automate the jobs to be done today. Whereas I think with your unique model, you're able to kind of control the environment that allows you to have the freedom to do something more creative, right? Focus on care navigation, focus on patient education, focus on kind of all the support scaffolding around that patient's journey that otherwise most likely is not actually there, right? And I think it's also interesting because a lot of that scaffolding is an area that you control. You don't really have to deal so much with driving the behavior change and the adoption of a lot of these tools to the actual doctors themselves, right? Like, you're just saying, hey, we're gonna support your patient, and there's nothing more you have to do. At least that's how I imagine it. And I think it's such a clever business model, and it's a unique opportunity to do really cool things. And I'm super excited about the work that you guys are doing.
It's funny you bring up the physicians. I gave a lecture about a month ago, and trying to. I was set, and what they asked me was, "What is the benefits of the physicians in the clinic for Thyme Care?" And so I stepped back and I thought, "What is the benefit to the physicians for Thyme Care?" And I thought about, as a physician, what does that mean for me? And if you think about, I have a patient in the hospital that doesn't need to be there. I literally sat there, okay, it took me 10 minutes for a walk from my clinic to the hospital. And luckily, my clinic was attached to the hospital. But otherwise, you have to drive, right? Then you have to go into the hospital, log onto the system, which takes forever. Then you have to see the patient. And since they're in the hospital, they like to talk a lot. The family's usually there. So it takes a lot of time. You have to come back, you have to write a note, then you have to go back to your clinic. And there's a lot of time sucked for that. And how much better would that time be for me if I was in my clinic where I'm much more efficient seeing patients? Right. And so what I told the physicians, I kind of showed this to them. Look how much time you can save by keeping people out of the hospital. Mm-hmm. You can be better and be more effective as a physician by doing that. And then let me add on, what if your patients are showing up to your clinic on time because we've gotten their transportation and things done and they're healthy, right? We've managed all this stuff that's happening out there. And all you have to do now is focus on the cancer and the treatment and the patient outcomes, right? That's all you have to do. You don't have to mess with all this other kind of stuff that we can manage. And it resonated really well with the physicians because it's like, yeah, that's right. My patients, they show up to clinic, they're doing well. And I can focus on being a doctor rather than all the other stuff that you don't like to do.
Yeah, I mean, it's a lot of the, I hear from, our users and oncologists all the time, like there's a very different level of care you need to provide to somebody that has a huge support system, that has their family there, that's super involved in their treatment versus somebody that is alone and may have trouble with transportation, may have trouble with laundry, may have trouble, remembering their medication, all these things. And it's like, I think the work that you can do is really even the playing field there by providing everyone that level of support in a way that allows the patient to show up for their treatment in the best way possible.
Exactly.
So, this is an AI podcast, and we have some interesting conversations in the past about AI. I'm curious if we can start by just sharing a little bit about some of the implementations where you've seen the implementation of AI, maybe at Thyme Care or just in your daily practice, that really inspired you or really opened your eyes to bringing kind of AI into practice.
I think the things that I've seen that are so helpful. One, we'll talk about this, but using ambient AI to document encounters. I think
We'll talk about this.
it that is a big time saver. We use that for our care team now as they talk to patients. We record those calls and then are able to give them a summary of that work. And it saves them a significant amount of time rather than having to do that, take notes, and then type all your notes up afterwards. I think that's a big one. One of the biggest things that I have found that we are using now too is a chart summary. You get all these records from patients. There's all this information in there, and being able to summarize that quickly, which is the one thing I think AI does really well, to give you a snapshot of that patient, and where you can then dig in deeper if you need to for the things that AI might not have shared with you, or you need to kind of make sure it's correct or things. That's a huge time saver as well, to give you that snapshot of what's happened in the past. And then the predictive modeling, I think, is really helpful too, where you can, it gives, the kind of the next best step kind of approach, where you can take this and it can help you kind of narrow down your treatment and your recommendations for a patient. And then I think the other big thing is translating stuff into things patients understand. Which is, one of the other things that we're working on too is, I can tell you, I live in Texas. I don't speak Northeastern very well. I speak Texan, and just being able to do little things like that, so you can translate what we're saying into things that people understand that are meaningful and resonate with them, is super helpful. I think AI does that really well too. And that's just kind of starting the cusp of what I think that possibilities are.
It's really the tip of the iceberg. And I think a lot of these things are, especially ambient, like we discussed, it's really reaching exit velocity and becoming part of the standard of care in oncology. But Layden and I have been friends with him for a really long time, and we always joke that throughout all of our friendship, he's refused to use DeepScribe. And so, I figured this would be a good opportunity to, I promise you, I'm not going to turn this into a sales pitch, but I think it'll be helpful to kind of walk us through, how you're thinking in the day-to-day life, and what is the process that you're going through to decide whether or not to adopt a new technology. One of the things that we struggle with is, there's always this natural adoption curve, right? There's early innovators, late adopters. I would categorize you as a late adopter. And we always, try to figure out, how can we get you guys into the fold earlier? And so, walk me through that decision of why, if all your colleagues are saying this is amazing, like why aren't you, jumping on board?
It's a really good question. And as we talked about that, I literally sat down and started thinking about who I am as it relates to technology. And what I realized, I'm a huge fan of technology. I think this stuff is fascinating. I'm a proponent of it. I love having this available in clinics for physicians to use and manage. So from that space, I'm a huge fan. And I've heard, like you said, routinely from folks at Texas Oncology, where I still practice a day a week, the benefits of the ambient AI with DeepScribe. for me personally, I've always been a late adopter. I just any sort of technology, I'm a late adopter in. It's funny, my kids literally today, the Spotify came out with their year-end review, and they're like, "Dad, what's your year-end review?" And I'm like, "I don't listen to Spotify. I listen to the radio." um, and I was like, the only time I listen to Spotify is when I'm with you, or if I'm listening to a podcast, because I do that through Spotify. And so it was so funny, and they're just like, um, but I'm personally a late adopter. And as far as it relates to ambient AI, I will tell you, I was a transcriptionist in college. That's one of the many jobs I had to get through college. And I literally typed my own notes until probably right before COVID. I typed most everything myself because I could type 120, 130 a minute. And so I would just do it. And then I finally started using dictation support, and that was helpful. And now I kind of use that and type. And I've thought about ambient AI a lot. And I will tell you the biggest challenge I have, and this is just me being an old fuddy-duddy, I think, is just the time it takes to actually get it right. And that's probably why there's a barrier right now. And I've thought about it since we've been speaking, especially, y'all came out with this new chart summary feature, which I'm super interested in, because that is one of the biggest pains I have, is having to click through thousands of documents trying to find the thing that you need. And so I'm super interested in that. That's gonna probably get me over the edge, I think, to start using it. But it's really that change in behavior to me is hard. And that is, for me personally, that is my biggest barrier, is that change in behavior and spending the time. Because, using it, it's not any of these technologies, as easy as you try to make it, it's not like you're going to sit down day one and it's going to be perfect.
Exactly.
You've got to spend the time to make sure that you understand my preferences. I understand how to use it, what I need to say in the exam room differently so that it catches those things. There's a learning curve to any of this.
Totally.
That's my biggest barriers. Do I really want to spend the time doing this learning curve, or am I perfectly happy in my old-fashioned ways of typing and using a dictation to keep it that way? And so that's where I am. And it's taking some things to say, but look at these cool new shiny little things that you can do. That made me go, baby, I'll spend the time.
Yeah, I mean, I thought it was so interesting, when you and I were talking about it, we spend so much time trying to build the perfect note out of the gate. We want to reduce the time to value and all the stuff that we have to do to make the note look like yours without having to get as much feedback from you. So, we do a lot of things where we analyze all of your past notes and generate a preference profile for you so that when you use it, it's already something that looks kind of like what you've written in the past. Now, a lot of times doctors are saying, well, that's a bad note. And I look at them and say, well, that's the note that you've written. So, and so a lot of times, doctors want us to help them write a better note. What I found really interesting about what you said was it wasn't just about the documentation that is the draw. It's really around what else can the platform do. And, there's a lot of people like you where, maybe they've tried ambient and, they were transcriptionists in their past and they're just so efficient in their workflow. But when we release chart summarizations or we release, other features on the product, they're like, wow, that was the thing that, really helped me dove in. And I think the big, sea change that we're seeing last week, I was talking to Dr. Doug Flora at St. Elizabeth. He was on the podcast. And, we were kind of talking about like the adoption of AI. And I thought what was interesting that he said was like, at a certain point, it becomes more than just these individual use cases that these point solutions are providing, right? I think at a certain point, the AI is, by being able to be a part of all the different points of the value chain or all the points in the workflow, we'll start to be able to at least build the infrastructure to identify things that maybe the physicians themselves would have missed, right? And when you start thinking about it that way, or if you do believe that, the adoption of these tools really start to feel more of a like strategic imperative rather than like a discretionary tool that, Lalan for the past 2 years is refusing to use. And, I think, and I'm optimistic, so I'd love to get your take, but like, I think that point is coming, right? Where, when I was talking to Deborah Patch, she said there's all these Ferraris of medicine, right? Where we've been able to build all these predictive models to help, doctors, practice better medicine. But there's no roads for these Ferraris to drive on, right? There's no way to actually, is there a seamless way to get these tools to the hands of the physicians? And so, I'm curious to get your take, like how far do you think we are from, looking at AI or just ambient technologies, maybe it's an easier question, as part of like the real standard of care, because eventually, it's important that we're able to harvest this information because it's going to be the benefit of the patient's health.
Yeah, no, I think you've hit the nail on the head. And that's another thing that I've been thinking about, starting to use DeepScribe. Because one of the things that I didn't mention earlier, I'm one of those physicians that when I sit down to do my note, that's when I think. It's when I really sit back, because in the middle of the clinic, it's really hard, right? You've got patients out the door waiting on you. You don't want to keep them waiting forever. You're seeing the patient sitting in front of you, and you're trying to get everything done in that 15-minute spot so that you can move on. And many times it's when I sit back and do my notes, and I'm one of those that kind of make sure I have some time block for my notes. I do my morning notes at lunch. I do my afternoon notes, as soon as I finish clinic. But I sit and think about the patients. I review things. Is it time for a CT scan? Did I order this? Did I miss this? I think that. And I think you hit the nail on the head when you're talking about AI as a strategic partner, because it'll help you think better. And I've seen that. I've started using, we just installed ChatGPT for our internal use. And so I've been asking it questions, and it's amazing to me how it can help me think better and not miss things that I may not think about, right? And so I think that's going to be really helpful in healthcare. It's just making sure, those prompts of, it's time for a thyroid test. They're on this drug, and I might have missed that because I forgot that it's been 8 weeks since they had the thyroid test. Because as the rapid pace of change in oncology is happening, it's hard to keep all of that stuff in your head anymore. A lot of these new targeted therapies have such unique side effect profiles. You can miss some of the little things that this drug in particular you may need to be doing that you just don't remember off the top of your head. And spending the time reading and researching that every single time I see a patient is you just can't do it. It's untenable. So I think that's a big one. And then the other thing, like you mentioned earlier, I sit in front of a patient, I take notes. I still have a pen and paper that I write notes with because I want to be looking at the patient in the face as I'm talking to them to show that empathy and get that connection. But I think we've talked about this. I think AI is getting to where it can help you with that stuff too. It can help you make sure that that little thing the patient said, there may be more to it than what you caught personally, or things you might have forgotten to write down that it could potentially prompt you to say, or to check into. Do they have an underlying social need that I may have missed? Do I need my social worker now to reach out to them? Because I missed that little comment they said that implies a bigger problem, and I didn't do my clarifying questions with them because I was too busy, right? So I think there's some benefits there too that we're just now scratching the surface of that will truly be helpful in driving better patient care.
Yeah. I mean, that's what I'm really excited about of what we built, right? We call them nudges internally. I think we might have to come up with a better name, but it's these nudges where they're not intrusive, but they're in context for that patient in the right time in the workflow where we're saying, hey, we spotted something, maybe this is helpful, right? And it's about changing kind of that choice architecture, because when you're so busy and you're seeing so many patients and you're behind, you can miss things, right? Who's to say that, you're as good as, when you're at 8 a.m. on Monday versus 6 p.m. on Friday. And so having that AI partner there with you to make sure that you're able to practice at the top of the license is what we're most excited about. If you had to pick one type of nudge to start with that you would just love, what would it be? Would it be around clinical trials, like this patient's eligible for this trial, or hey, you forgot to order this test, or what do you think that for you, what would you pick as the first nudge that DeepScribe builds?
For me, as a general oncologist, and I only practice a day a week now, so I'm not in clinic full time, which is also more challenging because I have a lot of other things that I'm working on other than just seeing patients and taking care of them. to me, it would be the nudges around toxicity management because we miss a lot of that stuff. And like I mentioned earlier, many of these new drugs are coming out with unique toxicities that I may forget to ask them about or dig into patients with or ordering those tests. So I think if we could make sure that those nudges were like, hey, don't forget to ask about this. Don't forget to order this test because this drug can cause these things and this is important, would be really helpful for me in particular. Is that, and then I love all the other nudges too. I think there's so many things that we just your brain just can't keep it all in that could help you manage that better. And then thinking about who needs to get nudged, I think is the other big thing. One of the things that I worked on a lot. One of the things I always talk about is a physician needs to be butt in chair sitting in front of a patient. That's what I want the physician to be doing all day. I don't want them doing anything else. I want them butt in chair seeing a patient. I want the staff doing all the other things that don't require a physician to be sitting in front of a patient. So as you think about nudges, like who should be nudged? Can this be a nurse that can manage this, a nurse practitioner, an MA? Is there somebody else that could get those nudges so that the physician's time is spent sitting in front of a patient? Because I think that's, if you look at all the studies of burnout and stuff, it's not physicians aren't burned out because they're seeing patients. They're burned out about all the other crap that they have to deal with.
Exactly. Because they're not seeing patients and they're using time to not see patients.
Right. Yeah. So they can sit in front of a patient and they can spend that time with them to have those, like we talked about earlier, have those conversations and really understand that patient in front of them and making the decisions that are right for that patient sitting in front of them.
Yeah. It's really interesting. When I ask that question to people, I get, answers all over the place, right? I've talked to doctors that tell me, I just want you to help me remember my patient's dog's name. Or, and then I have other doctors that are like, I want the, AI to help me figure out what the optimal therapy is. And it's so spread out that it makes it difficult for us to really pick one to start with because we want to do it all. But I think that's the hard thing about healthcare, right? Like there's a threshold that you have to meet where all the physicians are a little bit different. And there's such a long tail of the requirements for the products that you have to build that you have to do the work to kind of get there before you're able to kind of have something that's viable. And so I'll add that one to the list.
Yeah, it's so true. I mean, physicians are people and every single oncologist is different. What motivates them, what kind of patients and cancers they like to see and treat. I mean, I can tell you from my experience, every single one of us is very different. Every single one of us wants something unique. And to your point, it's hard to manage that, as a vendor, because you can't customize. You can't just come in and customize everything for every physician from the get-go. You'll get there eventually.
Yeah.
You just can't.
I mean, it's a partnership, like you said, right? Like, I always tell physicians that it's a tool, you have to learn how to use it. And if you invest the time to make it work for you, it'll be awesome. And if you don't write it off, like if it's not perfect when you start, right? But just to touch on the second thing that you said, which is really around like the nudges or the information that's happening inside the room, it may be more appropriate to funnel that to somebody outside the room, right? And I think that's the kind of core thesis of what we call the ambient operating system, right? Like, how do you take information from inside the room and channel it to all the right stakeholders and figure out ways that we can use AI to automate their work? And we've talked a lot about, how the ambient data or the information that's in these conversations is so unique. And it's also real time. So we don't have to wait for Lalan to finish his note for us to figure out all these things that, we have to do for the patient. And, sitting, in your chair at Thyme Care, I'm curious if you can share what information you think would be helpful for us to maybe inform you of so that it can help, accelerate the work that you guys do or improve the work that you guys do. Is it, because we hear about this a lot from the lens of just a normal fee-for-service organization.
Mhm.
But I think, you guys have a lot more of creative things that you guys are doing that, it'll be really interesting just to learn, like, what information can we send you that can help the work that you're doing?
Yeah, I think, for us, it really, how do we take what happened in that room and make sure that we're managing that 24/7 outside of the room work that needs to get done. So for example, if a patient, a patient had a side effect and the physician gave them a medication to manage that side effect, can we be alerted about that so that I know that my nurses need to call that patient the next day and say, hey, is that working? So that we can continue that at home. I mean, I can't tell you how many times I've had patients where, they may have diarrhea, for example, and I give them a script for Lomotil and I give them instructions how to take it. And they come back in the next time and it's not any better and find out, well, they weren't taking it the way I told them to take it. And so how do we have that connectivity to make sure that whatever happens in that room, we know so that we're following up with our care team on those things. And then you talked about nudges and predictions. Are there things that are said or unsaid in the room that we need to be alerted about so that we can think about things a little differently? Is there a subtle thing that somebody may have said? And I'll tell you an example that happened to me not too long ago. Sitting in a room with a patient and their family member, and I said something about treatment, and I just noticed that the family member got this look on his face, and it prompted me enough to stop and go, are you okay? Is there something that needs to happen? And then I got the whole information about him having to take off work and he was an hourly employee and then how, that was going to, he was his primary caregiver for his father and blah, blah, blah. If I hadn't noticed that or caught that, he would have just taken off of work, not gotten paid, and been in a financial distress.
Yeah.
But, there are things like that happen that we can then proactively kind of jump in and go, okay, hey, here's a problem you didn't want to talk about. And I work in a blue collar, more rural clinic right now. And so nobody ever complains about that stuff, right? They just suck it up and do it. That's just how this population is. So is there something we could do more proactively? Call them and say, hey, let me help you with this. Let's see if we can find resources and things to do that. Those things would be super helpful for us.
I mean, I think that's a huge opportunity because, sitting from my vantage point, having read, thousands, maybe tens of thousands of notes in my life, I could tell you there's a wide dispersion in terms of what a physician thinks is important and what they can remember, right? And, oftentimes I think physicians are trained to take kind of this reductionist approach to note taking, right? They, start with this conversation with the patient and then they have to think and figure out what do I want to include. And that process, is not consistent for every single one, everyone.
Yep.
And, this note that they produce ultimately serves all the different stakeholders downstream of the value chain, right? Traditionally, revenue cycle, you have quality teams, and now you have, organizations like yours that are doing work that I would say is like brand new, right? And I think the beauty of this is, hey, we don't have to rely on the physician to change the way that they write the notes to be able to feed that information to the rest of the stakeholders. You can still have the physician, not document, doesn't have access to clean laundry, doesn't have access to transportation, caretaker needs to take time off work. So I'm going to pick this therapy that has to be administered every 30 days versus every 7 days, right? Like, a lot of that stuff sometimes doesn't get documented, but we hear it and we can feed that information to all the other stakeholders in a way that's real time and is lossless.
Love that. Because you think about notes, I mean, historically notes have just been a billing tool, right? That's what they've devolved into is I need to do this so I can bill and get paid for the services I'm providing. But in reality, they're a communication tool. Your notes should be communicating to everybody else what's going on with that patient. And so that you can, to your point, make sure that, everyone is managing that patient the way they need to be managed. And I love the way you just phrased that because it is. I mean, notes should be a communication tool, not a billing tool.
Yeah. And that's why, again, like I'm so excited with the work that you guys do because I think traditionally, we think about the ambient operating system in a way that is categorizing information for the work to be done today. And the to be done today, I think, is so influenced through the policies, through the current infrastructure, all the macro things that we've talked about. Whereas, you guys have been able to kind of create, your own fiefdom where you can do all these creative things and you actually have a commercial model to be incentivized to do so, right? And so I think, if we really want to show the world or demonstrate the power of a lot of these tools, you have to do it in an environment where number one, people are open to innovation.
I'll start using it. I'll start using it.
Just kidding. I'm just messing with you. But number two is like the commercial model needs to be aligned, right? And what I talked to Dr. Paulson, and one of the first few times I met him, he told me, Matt, no margin, no mission. And it's so true, right? Because healthcare is a science and it's an art, but at the same time, it's a business. And without it being a sustainable one, it'll just fail for everybody. And it's true. And so I think what I'm so excited about this conversation and having have met you is like all the work that you guys are doing to change this system that we're in. And I think the amount of potential that the company has to implement a lot of these AI tools is so much more ripe than having to deal with a lot of the friction points that a traditional provider organization or practice would have to deal with. So,
yeah, no, I completely agree, because we were focused on outcomes, things, rather than doing and checking the boxes, but you're really focused on outcomes. Your whole perspective changes.
Exactly. Yeah. So, Lalan, I know we're coming up on time here. I'm curious, the last thing that we ask all of our guests is, what is one thing that you wish people like me or like vendors or technology tech bros, what is one thing that you wish like we really just understood about healthcare or about the work that you do that maybe we don't appreciate, or had we appreciated, we would have, built something different. And then, also vice versa. Like, what is one, after working at Thyme Care and sitting at the vantage point that you're in, what is one thing you wish more doctors really kind of just understood a little better?
One of the things I think many vendors run into is they're so focused on the physicians, and they forget that cancer care is really a team sport. And it takes all of us. And this is true in clinics too. Many physicians forget that they can't actually do their job well unless they have the team surrounding them. But really understanding what the role of all the different team members are and how can we use technology to not just improve the physician's lives, but everybody else's lives around them. Because once you do that, the physician's lives will be much better too. And so if you focus too much on the physician only, you're missing all of the support team that is required to help that physician work to the top of their license and also improve the patient outcomes. So that's number one I would say to vendors is don't forget that cancer care is not just a physician and patient. It is an entire team that's supporting and surrounding that patient. And then for your second question, what I would like to learn more, because I'm just pretty naive and not nascent about this stuff, obviously, what are the true possibilities of where we could potentially go? I kind of scratched the surface a little bit, but I think there's so much opportunity for companies like DeepScribe to do more and to improve the lives of our patients. It's just fascinating to me. Just thinking about where we were a year ago to where we are now, it just fascinated me to think about where we're going to be. And I don't have the imagination to be able to do that very well. So I love to learn more about what the possibilities will be.
Yeah. I agree. I think a lot of the literature or a lot of the kind of writing around AI and its application in healthcare is not really written for an audience of an oncologist that actually has to adopt it and change their workflow. Although there's a book that I'll send you. It's actually written by Doug Flora that he just released that does exactly that I think would be really interesting. But just on the first point, I wanted to share a funny story. you're so right. It's not about not just about the physician. It's about the whole care staff. And we learned that the hard way at DeepScribe, because the first week we went to go implement DeepScribe at Texas Oncology, I was looking at the number. I was like, how can we only, onboard so little doctors? And turns out we spent the first 3/4 of the day trying to get through the front door because they wouldn't let us in there. And we look back and laugh about it now, but it's like, wow, we didn't even think about that, right? It's like something, I think it's a very symbolic story because like even getting through the door, getting past the front desk, right? It's a whole team effort. And, a lot of times there's so many gatekeepers to the actual physicians that you need to figure out how do you deliver value for everybody as part of that patient's journey, not just the physician. Well, Lalan, I really appreciate the time today. I had an amazing conversation. I'm sure this will be the first of many. And thank you again for joining us.
Yeah, no problem. And maybe I'll come back after I start using DeepScribe and I can tell you all the great things about it.
There'll be a part 2.